Welcome. We'll get started in just 1 or 2 minutes with our Monkeypox special grand rounds. We may have one or two, few more people coming in from the atrium. So give us just a moment and we'll get started. Well, thanks to all of you for coming. We want to honor your time and commitment to being here right at the starting time. My name is Dr. George Rust. I'm a family physician and preventive medicine public health specialist. My role here today is as professor and director of the Center for Medicine and Public Health at FSU College of Medicine. I do play a role in clinical support of our local county health departments, but I need to make the disclaimer that I do not in any way speak for the Florida Department of Health, and opinions I say will not represent their views necessarily. I'm pleased to have a panel of experts with me whom I'll introduce in just a moment, but we'll start with just some basic background information about monkeypox, which is sort of a new disease to all of us. I have seen cases of it now. It is now on the list of diseases I do not want to get, but we are seeing it in our community and in our state. This slide is just to remind me that it is a virus. This is a conceptualization of it, and Dr. Riscala will end up giving us better biology of this, the capsule and so forth around the DNA. It is capable of infecting both animals and humans, and there is an animal reservoir in Africa, but not in the United States at this time. Different rodents such as rope squirrels, tree squirrels, pouched rats, dormice, etc. Not so much in monkeys. The name is a bit of a misnomer. The main reason I wanted to put this slide up is that viruses don't have brains or hearts. They don't love or hate. And they really do not care if we're gay or straight or bi or cis or trans or how we gender identify or even what mammal we are. Monkeypox has been around. First case known to be diagnosed was in 1970. It was diagnosed in Africa. There are two clusters, genetically distinct. They're called clades, one in the Congo Basin, one in West Africa. And in that context, there's been a low smoldering set of infections, a couple hundred a year typically, with as much as a 3 to 10% case fatality rate. In 2017, there was an outbreak in Nigeria and moved into some of the urban areas that allowed it to begin gaining access to the world. Over 500 suspected cases at that time and a case fatality ratio of about 3%. This is what it looks like now. The little blue dots in Africa represent those endemic areas. That only represents 443 cases in the past year. So all of the other 51,257 cases around the world are happening somewhere else where it didn't used to happen. And so we see just how quickly there has been, not necessarily worldwide, but in many continents of the world, many countries of the world, we're seeing monkeypox cases breaking out. It has appeared in the United States once previously. These cute little animals are prairie dogs, and for whatever reason, Americans buy funny pets, and they were buying prairie dogs at that time. The prairie dogs were being shipped with some Gambian pouched rats that had monkeypox. The prairie dogs then passed the infection to humans. There were 71 people ultimately infected across 6 states. But what I really want you to pay attention to is the timing there. In 5 weeks, public health figured out what it was, got on top of it, did case identification, did contact tracing, and by June 20th, 2003, the outbreak was extinguished. So there is a possibility here to identify, to do good public health, and to extinguish the outbreak. And this is not COVID. U.S. experience to date, we're up over almost 19,000 cases in the U.S. confirmed. 4.3% hospitalized. I put on here 0 deaths, and as the world would do, it waited till this afternoon to notify me that there has been 1 death in Houston, Texas, that they're referring to as a person died with monkeypox, not a person died from monkeypox. This was a very sick individual, very immune compromised, and the immediate cause of death is not known at this time, but there has been 1 death in a person who had monkeypox. Florida is running about 10% of the cases in our country, 1,900 out of 19,000 roughly. Interestingly, we're running about 1/3 of the pediatric cases. So we've had 22 pediatric cases here in Florida, 60-something cases nationwide in the pediatric population. Again, I had to change my slides today because the slide I had in here showed an exponential growth up. We were doubling cases about every 9 days at the beginning of this. But we have plateaued out, and there has actually been a 20% decline in cases over the past week or so. So there is good news on that front that maybe we're beginning to catch up with the outbreak. Happens in all ages. This says range 18 to 76 years, and then they have a clever little football that says not counting the pediatric ones. So basically from age 3 and up, there have been cases, but it's concentrating in the 20, 30, 40-year-old age group. More among men who have sexual contact with men at this moment. I will say that that is a social group within which it is multiplying at this time. There is no reason to believe that this virus cares which group it multiplies in, and we have a very good chance of seeing it jump out of that population into other populations. We'll look at the risk behaviors in a minute for that. What does it look like to get the disease? And again, we've seen cases now, a number of cases over at the county health department. Starting with constitutional symptoms, headache, fever, swollen lymph glands, myalgias, for all the world feels like the flu. And we are about to come into flu season. But then the rash begins to develop, a rash that has a specific progression. We'll look at that in just a minute. One distinguishing feature for some patients, but not all, is enlarged glands, enlarged lymph nodes in the neck and above the shoulders, and in the groin area. Those lymph nodes are one of the telltale signs. The lesions themselves, there are classic cases, and then there are cases how they happen in the real world. But the classic cases go through this progression from what we call a macule, a flat little lesion, to a papule, a little bump, to an early vesicle, a small blister, to a small pustule, looks like a pimple, a little whitehead. That pimple then may form a central little indentation. We call that an umbilicated pustule, which then progresses to that thing ulcerating and forming a little scab in the center of it, and ultimately the whole lesion scabbing over. The ones I've seen so far, many of them are exquisitely tender. These are some other ways that the rashes can look. One other distinguishing feature, some of our patients have had rashes on the palms of the hands and the soles of the feet, and that's kind of different from most other infections with the exception of syphilis. And the syphilis lesions typically are non-tender. This is what we've seen in the United States cases. So this is a little bit different than what they've seen in Africa in the classical cases. But the rash in 98% of cases, I think because we wouldn't even suspect it if we didn't have the rash. So there may be some cases slipping through that didn't have a rash. But the constitutional symptoms, fever, aches, chills, the lymph glands, the swollen nodes, in about 2/3 of cases. The difference here has been the anorectal symptoms, people having anorectal lesions and fairly significant anorectal pain, bleeding, mucus, and other symptoms in that area. Again, about 4.5% hospitalization rate and maybe 1 death in the whole country. This would be a picture. that illustrates in some of the U.S. cases, we've not seen the total body rash that is typical for this in Africa. Seeing just lesions in the mouth or just lesions in the anus, just lesions in the genital area. And it doesn't always appear on the palms and soles. We can do testing. One of the messages we've been trying to get out to local doctors is that if you can do a herpes swab in your office, you can test for monkeypox. We've been trying to avoid the messaging that, well, if you need a monkeypox test, just go to the health department. No, don't do that. With the staffing, that would stress the whole system. Most doctors' offices should be able to do the test for this. It's a swab, it goes in a certain kind of tube, you keep it in the refrigerator, and you send it to the lab. How is it spread? Prolonged direct contact is what I would say. Prolonged direct contact with the virus, especially oral, genital, anal. In other words, think about skin that does not have the dry skin, but is more moist skin. Inside of your mouth would be the example. You can transmit it dry skin, but this skin has more layers, and the dry skin layer is more of a barrier to transmission of the virus than the inside of my mouth or other parts of me that are moist parts. You can transmit from physical objects to skin or mucous membranes. I think that's what scares folks, but it's usually with prolonged contact. So to look at a continuum of risk, to try and make sense of this so you're not afraid to touch every doorknob that you pass through. The continuum of risk way over on, I guess, your left, my right, no, your right, would be sex with multiple partners. That's how a lot of cases have been transmitted so far, or with one infected person. That's putting you at the most exposure of mucous membrane to mucous membrane, rubbing up against each other in a prolonged manner. That's the easiest way to transmit the virus. Prolonged physical or intimate contact, making out, kissing. One of the things we saw in the meningitis outbreak last year when we did contact tracing with young adults and college students is that they do a lot of things that end up transmitting their bodily fluids to one another, and things like beer pong, drinking out of the same glass at the bar, using the same vaping device. All these kinds of things can put you in contact with somebody else's saliva. That would not be so good. Music festivals have been one of the venues in which there has been some identified spread. People wearing relatively little clothing, dancing in close contact in a large crowd, and rubbing up against each other for hours. There have been some cases transmitted that way. Even less likely, close household contact. But if you're sharing a bed or a room, or you're playing beer pong with each other on a regular basis, or sharing drinks out of the same glass, that's a possibility. Sharing towels, bed sheets, or blankets, yes, it can be transmitted that way. No, that's not how most of the cases are happening. Is it possible? Could I set up an experiment where we transmit it that way? Yeah, sure. And unfortunately, we have the sad history in this country with American Indians that were wiped out, sometimes entire tribes, by blankets with smallpox being purposefully introduced into their communities, and individuals that were susceptible to smallpox being wiped out in that way. So these are all the ways in which and the mechanisms by which the virus can be transmitted. To summarize risk, a sex toy is, I don't know, greater or equal than a toothbrush. They're both really bad. They both would be good ways to transmit the virus if you were trying to do it with a physical object, but much more so than a towel. A towel is worse than a bed sheet because of the moisture and the humidity. Clothing, it's much harder to transmit just through clothing than through laying in the same bed with the bed sheets. Hard surfaces, could it survive and could you potentially catch it from that? Maybe, but super unlikely. The virus is susceptible to UV light, so exposure to sunlight, exposure to light does kill it, and exposure to dry air can kill it. Moist places and protected areas are a little bit easier for it to survive. So keep in mind that continuum of risk. If you do get it, I'm not going to go through all the details of this, but the bottom line is you may have it for 2 to 4 weeks. We'd love for you to stay home and not see anybody or talk to anybody, but that's not realistic. So if you can stay home during the constitutional symptoms, the fever, chills, etc., that would be more better. And as long as the rash persists, until the last scab falls off and you have clean, dry skin underneath it, you are still infectious. So covering those up with bandages, wearing clothing over top of that, wearing a mask, all of those things would be expected, and then using hand sanitizer and frequent hand washing. We do have a vaccine available. Initially, we thought we had a very super limited supply because we were giving it subcutaneously. You could only get 1 dose out of 1 vial. And so at that point, we were only vaccinating contacts of known cases. But now with the intradermal technique, we're getting 5 doses out of each vial. And because of that, Florida has jumped to phase 3, where we're vaccinating basically anybody in a risk group. People who have multiple sexual contacts or other risk factors, immune suppression if they're immunocompromised in any way. It is a 2-dose vaccine, by the way, the second dose at 28 days. So we're in the zone of not just post-exposure prophylaxis for known exposures, but even for presumed exposures or risk behaviors that could have exposed you, we're going to go ahead and give the vaccine there. This is what we mean by intradermal technique. If you ever had a TB skin test, that's what we're talking about. And we do have a number of folks in the community giving those vaccines. That dosing regimen has been tested with other vaccines, but also with the attenuated vaccinia virus. That's what's in the vaccine that we give. It has been tested intradermally and been proven to work. I should say about the vaccine, this one, the Jynneos, is one of 2 smallpox vaccines that were in the national stockpile. One of those is the old-fashioned smallpox vaccine that you take a little fork and have a drop of the fluid on, you stab it 15 times into the arm, and then it replicates and turns into a blister in your arm. This is not that. This Jynneos vaccine is a live virus, but it does not replicate, so you can't pass it to anybody who's immune suppressed. We give it as just a regular, as you saw, a regular needle and syringe. Reactions people are getting, everybody says it itches afterwards. Everybody says it turns red afterwards. About half the people to 2/3 of the people say it hurts a bit afterwards, typically given on the forearm in the intradermal dosing. And some people are getting mild constitutional symptoms, a little achy for the next day or so. We do have treatment for the monkeypox virus. It's called TPOXX or tecovirimat. And I'm not going to go to the details, but basically we're holding it for people who really need it. Immunocompromised individuals, kids under age 8 are at high risk for a more severe form of the disease. People who are pregnant or breastfeeding, this virus can do bad things to babies. And people who have skin conditions that might lead them to get much more massive scarring. The folks who are having a lot of pain, either rectal pain or oral pain, we're also giving the TPOXX to. Where do we go from here? What could happen? Well, it could happen with universities back in session and people playing beer pong and sharing beds and body parts, that we could have transmission jump to the heterosexual population, to people who are having sex with lots of different people, or in some other way having close contact with one another, music festivals, raves, dance clubs, those kind of super spreader events potentially. And worst case scenario, it spreads to an animal reservoir here. We have not seen that here in the United States. But another potential future scenario, and think back to that prairie dog outbreak, is we could eradicate it. We get ahead of it, we do contact tracing, we identify cases, we jump on it, we vaccinate people around the cases, we vaccinate the people around them, we vaccinate people with the risk behaviors, and the outbreak is extinguished. And right now what we're seeing is a decline in cases that suggests that maybe public health at least is starting to get a handle on this. So I'll just close with this. May I please remind us that public health remains important. If we haven't learned that in the past 2 years, I don't know that we've been paying attention. With that, let me turn to the smart people on the stage and suggest that we ask them some questions. I mentioned COVID, and unfortunately COVID took down one of our panelists. Dr. Van Dermy reported that he is not able to be here for that reason tonight, and so our thoughts are with him and hope he's feeling better soon. We are very honored to have with us Dr. Faye Tinson, a doctor of nursing practice who is the infection control director and also runs the Ryan White HIV programs at Bond Community Health Center. Dr. Raed Rizkallah, somebody just turned off my monitor, so I'm going to step over here to make sure I get it right, assistant professor in the Department of Biomedical Sciences here at FSU College of Medicine, and Dr. John Applebaum, chair of the FSU College of Medicine Department of Clinical Sciences, and an expert in HIV care, and has been on national media actually talking about the monkeypox outbreak. Dr. Tinson, would you like to start us off? Comments, reactions, things you'd like everybody to know?
Sure. Can you hear me?
Yes.
As Dr. Russ stated, I am Dr. Faye Tinson. I do have a doctorate in nursing practice. I've been a nurse for 30 years, so RN. In the latter 15 years, I've been a nurse practitioner, adult nurse practitioner. I've worked in many fields. I ended up working in public health at the community health center because I felt I was better placed in prevention, early detection, and treatment, and I actually loved it. I played an integral role in COVID vaccine distribution, testing, and looking forward to helping out with the monkeypox. And my primary role for infection prevention and control at Bond is to make sure that patients and staff are safe. I provide training, education, as well as I monitor the lab and our dental area and medical area for instrumentation, reprocessing, disinfection, and sterilization.
Very good. And Dr. Rizkallah, before you go, if I could just make one announcement. I do believe we have index cards. If folks have questions, we can pass those around and make sure that any questions get passed up to the front. We also have the ability on YouTube, if folks are watching there, we can have you email questions to pr@med.fsu.edu. I'm looking to make sure I got that right. PR for public relations, pr@med.fsu.edu. So if you have questions, email those in and we will be monitoring that. We're going to be passing around index cards if you have questions. And with that, Dr. Rizkallah, any opening comments you'd like to make?
All right, good evening, thank you. Yes, I'm Raed Rizkallah. I'm in the basic science, so I'm the one who get to say the boring jargon stuff. My opening remarks are a bit kind of a follow-up on a couple of things that Dr. Rust mentioned. If a few months ago, if you look up monkeypox, it would show up as it's a rare zoonotic disease infection that happens somewhere else in the world, in endemic regions. It occasionally jumps from animals in some regions to humans. You get a few cases. In PubMed, the published medicine research, if you look up monkeypox, a few papers every year, 80s and 90s, a big jump in the publications, 2003, when we got the big outbreak, to 40, 50 publications. And then you look at that and you see spike, no pun intended here, just a spike of publications, about 500 papers this year. So what do we know about this virus in terms of basic biology? Very little actually about the specifics. However, we do know quite a bit about the family that this virus belongs to, and that is important. That's why I want to spend 1 minute talking about that. We know quite a bit about this virus because we know of its family. It belongs to a family, as the first slide there, of pox viruses. The infamous star of this family, the smallpox, claimed hundreds of millions throughout history. probably estimate about 1 billion. So that has been studied well. Through comparative analyses of these members of the family, we know about the general mechanisms of how it gets into cells, the host range, what kind of doesn't affect animal, humans. You get quite interesting members of that family. You get all kind of animals. Then you get cowpox, you get camel pox, which kind of determines the specificity of it. Now, of course, this is a misnomer, as you mentioned. It's not targeted toward monkeys. Us and monkeys are incidental hosts. So I'm mentioning all of that, and a lot of research went into this after the 9/11, and that was very important because of the scare about the bioterrorism. All of that basic research is what allowed us to be not caught off guard today. We already were prepared. We just repurposed some of the antivirals, and we have a medicine, we have a vaccine. So all of that research has been instrumental in putting us where we are in the good place we are. Of course, with the public health, coming out of a pandemic now, we're kind of like already on guard. But that's important. But we also want to know that there's a lot going on with this virus that seems a bit interesting and unfamiliar. So complacency about you were doing good, that's great. But I think there should be a push of understanding more the basic virology of this. In the next few months, there's going to be a lot of information, some of it already coming out. That's going to be very important to stay on top of this situation.
Very good. Much we're still learning and why the research is so important. Dr. Applebaum?
Thanks, George. And I think you did a nice summary of what we do know about this particular virus. And, as Dr. Rizkallah said, there's a lot we don't know, and we're continuing to learn. There's like 3 points I'd like to make. Number one, I want to reiterate the fact that this is not COVID. This behaves differently than COVID. It's transmitted much differently. It's harder to transmit. So you can't catch monkeypox from being in the same room as someone. You actually have to have physical contact, as Dr. Rust discussed. And because of that, many people have claimed that this is a sexually transmitted disease, and I would take issue with that because it can be transmitted in other ways besides sexual contact. It certainly doesn't behave like the classic sexually transmitted diseases like syphilis or gonorrhea. And then the third thing is just an observation that sometimes it takes disease outbreaks like this to really magnify the healthcare disparities that we have in this country. And we have to be careful of stigmatizing marginalized populations. And so there has been some, I think, discrimination and stigma directed towards the MSM population, the population of men who have sex with men. But as we just heard from Dr. Rust, this can be transmitted very easily, and we can see that this could easily be a problem in the heterosexual community. So, and then the final piece about that would be that we are seeing other marginalized communities having issues with monkeypox, and there are some racial and ethnic disparities with this disease too. So I'm open to questions.
Thank you. And just to reinforce that, this happens to be circulating in one social network at this moment in time, but it just as easily, could circulate among prairie dog pet owners, and it could just as easily circulate among heterosexual college students. So I think we just have to be very careful about saying it's that group over there that has the condition. In fact, one of the questions we got is this disease more susceptible among the LGBTQ community? In other words, is the LGBTQ community more susceptible to this? Do you want to take that one?
Yeah, I'll take that. I mean, again, as you pointed out, the virus is not smart. It doesn't know what your sexual orientation is, your gender identity, but it does care the fact that if you have intimate contact with someone who has the virus, you will catch it. So, right now it is primarily among the MSM population, the men who have sex with men. But again, as we pointed out, it could easily be an issue in other populations.
Mm-hmm. So, Dr. Rizkallah, there's a question here about at what temps should clothes or towels be laundered to kill the virus? Maybe you could answer that in a more broad way. What should we do with our laundry? If we're in a setting, let's say a dorm setting or some other setting where clothes or towels may have been exposed, what would be reasonable ways to think about killing the virus without using torches?
Right. So the CDC have clear guidelines on the disinfection. That this is a virus that is an envelope virus. It is susceptible to a lot of the disinfectants that we used. So if you wipe surfaces, etc. The towels thing. This is a DNA virus that it's enveloped. It's susceptible to drying, susceptible to UV. But it's also one of the largest viruses, so it's a stable virus. That's why it can stay for a long time. That's the main concern of it. So when we talk about towels, they're going to be wet. They're going to be allowing that environment for it to stay. Temperature, if you look at the actual guidelines, 1 hour, 60 degrees Celsius would kill it. So if under that, it's kind of different kind of circumstances. But if you wash your clothes regularly, if you're boiling, if you're in the washer, etc., that's gonna definitely get rid of it.
So both a hot water wash, but also you mentioned earlier the detergent in the wash.
Detergent
The
will
capsule
also-
is susceptible to that detergent, correct?
Yeah, so it's a large virus, so it's stable if it stays for long, but it is very much susceptible to most of the detergents. And the CDC would have clear guidelines. That I know the exact numbers now, but they have clear guidelines about the disinfection. But it should be pretty susceptible to washing and all that.
So you're saying basically that normal washing in the washing machine with whatever detergent you choose to use,
Should
and then
take care of
drying
it.
in the dryer should kill this virus.
Should definitely
Yeah.
take care of it. Yeah.
And if you don't have a dryer, hang it out in the sunlight because it's also susceptible to UV light. So the virus can be killed. You know, what has all of us always hedging the way we talk about this, there has been, for example, a virus discovered in the house of someone who had monkeypox 15 days after the house was uninhabited. So it does have that ability to live for a long time if the circumstances are optimal. If you have that moist towel in a relatively cool, humid environment, it may survive. Now, whether or not it's surviving in enough numbers to reach the inoculation dose to actually infect someone else, that's a second question. So much of this, we don't have the precise research to answer those questions. But
the one thing I want to say, that the good hygiene habits that we got into recently, should we keep doing that, and that will help with this and other viruses as well.
Right. I should mention one of the reasons in the isolation guidelines for wearing a mask is that this is not transmitted like COVID. It certainly does not hang in the air like an aerosol. But if you're at a music festival and you're jumping up and down and dancing with 30,000 of your closest friends, face to face and shouting to be heard above the music, it is possible that some of your saliva might leave your mouth in a big enough droplet to get onto somebody else's mucous membranes. And so it is, again, possible to transmit that way. The real risk is over here with mucous membrane to mucous membrane, sexual contact, oral contact, anal contact, genital contact. That's where most of the transmission is happening. But if you ask me, could it be transmitted that way? Yes, a mask would prevent that. Hard surfaces, very unlikely that it's going to be transmitted. So the concerns about doorknobs or sitting on a hard plastic chair, very unlikely that you're going to transmit it that way because of the fragility of the virus. Now, Dr. Tinson, you deal with questions from the community, I'm sure, from time to time. What are you hearing in terms of what are people asking you, and what are the either the biggest concerns or the myths that you might hear that you feel like you have to sometimes rectify in your conversations?
Well, as far as the health center, whether or not the health center is safe, just with this recent outbreak of monkeypox, do we have to do the same thing that we did with COVID? Should you close down, and should we only practice virtually? So we've had to, notify our staff and our patients that the health center is safe. We do practice high-level disinfection, cleaning, and of all of our hard surfaces. I removed anything that's porous, so everything's non-porous. So that's our biggest question. We do screen for monkeypox as well as COVID still at the front entrance. So that was our biggest concern, whether or not it's safe to come into the health center.
Any of you, are you getting questions about the vaccine?
Yes. So, I mean, the biggest question is availability.
Okay.
And while they've released lots of vaccine from the stockpile, it hasn't reached the health center. So there are some of us in Tallahassee that have vaccine. I'm not sure what Bond's doing, but I know what we're doing, which is just vaccinating our own patients who are at high risk using the level 3 guidelines that you put up on the slide. But we're not generally advertising that we have the vaccine because we're concerned about the supply. We've actually held, because it requires 2 doses 28 days apart, we've actually held back doses so that we know that we have enough for the second dose if the supply doesn't make it. So, and this is part of some of the issues in the community, particularly in the LGBT community, feeling that maybe the government response has not been quite as robust as it could have been. And for the older folks, thinking back to the early days of the HIV epidemic, which similar type of concern about government response. So, I think the good news out there is that we are able to stretch the vaccine using the intradermal approach. I will say that we have not always gotten 5 doses out of the vial. Sometimes we're only able to get 4, but
Okay.
yeah, but it is better than 1. And the stockpile, they are releasing more vaccine and they're making more vaccine. So, and that coupled with the good news about theoretically the decline in the incidence, hopefully that will stay. I think people should feel better about that.
When the government first committed to buying 35,000 doses of the monkeypox vaccine, there was criticism that they were overreacting. And now we're of course trying to stretch the supply as far as we can, and they're scrambling to buy more doses. And it looks like we are getting ahead of that curve. But I'll talk to you later about tricks to get that fifth dose, but the kind of syringe you use matters there. How effective is the Jynneos vaccine in preventing monkeypox infection or symptoms? How do we know? Any of you want to take that, or I can roll on that one if you want?
Well, I think they are trying to get clinical trials to get more conclusive results on the efficacy. We know about the safety very well. The safety is pretty well established. The efficacy have been done in animal models. And I don't think we have a conclusive answer at this stage of the actual numbers.
Well, there's a number, but we're not.
We know it will offer protection.
Yes.
The numbers, we don't yet know because we don't have the actual randomized trials, et cetera.
Right, and again, extrapolating from other studies, whether from animals or whether from some of those German uses back in when they were vaccinating against smallpox and looking at antibody levels, there's different ways that people are judging it, but the current number that's being used is 85% effectiveness. Now, you reach maximal effectiveness 2 weeks after your second dose, but there does appear to be evidence that if you get the vaccine within 4 days of when you had, let's say, sexual contact with a known case, that if you get the vaccine within 4 days, you will actually prevent getting an infection. If you get it within 4 to 14 days, you might diminish your risk of getting the infection, or you might just have a milder case. So that's the current, as best we know, and to be continued as we vaccinate more people.
Yeah, and I just want to emphasize the fact that you're not fully protected until 2 weeks after your second dose, which would be 6 weeks after you got your first dose.
Right, excellent. Good, so I'm scanning questions as I go along here. So we've got one big picture question related to the community, and then sort of a granular person, a question that has personal implications for folks. The big picture question is, with flu season approaching and COVID rates potentially increasing, or at least still high, would healthcare workers, hospitals be prepared if there was a widespread outbreak of monkeypox, especially in large cities?
Well, I'll just say the good news is monkeypox is a self-limited disease, and it tends to be taken care of on an outpatient basis.
Right.
You showed the numbers that there are very few that actually end up getting hospitalized.
Right.
So the answer to that is I think we're okay, assuming we don't have a huge COVID surge like we did last year.
And since the clinical picture for monkeypox is about 4 weeks, hopefully, if we don't have a huge outbreak, then that shouldn't be an issue. But if we do, then people will have to isolate at home. So you'll be removing those people from the general population to decrease the spread. And like Dr. Applebaum said, it's self-limiting. So eventually you'll recover as long as you have a pretty healthy immune system.
One of the, I don't know if this is good news or bad news if you have a case, but good news from a public health perspective is that that many of the cases become fairly obvious at some point, so that you can identify cases. The rash breaks out or the rectal pain comes up and there's no other explanation for it. So that we do identify cases, we do get good contact tracing, and so we have that ability to then vaccinate the contacts of the contacts. And when you go back and think in history, smallpox was this horrible worldwide disease, which in 1980 was declared eradicated from the globe by the World Health Organization, just because of those aggressive public health efforts around the world that found every case, vaccinated the people that were around those cases. If a village had an outbreak, then they vaccinated the villages around the villages. But they were able to completely extinguish that virus from the world. So monkeypox, I think, is different from COVID, both individually as symptoms, but also as a public health problem. A little more obvious to identify, much lower case transmission rate. COVID right now in the current strains is a single case of COVID is likely to infect more than a dozen other people. That is not the case with monkeypox. So what they call the R0 values are dramatically lower for monkeypox, makes it much more containable if we get out ahead of it. How do community folks get access to the vaccine locally if they do not have a doctor? We've got CarePoint, we've got Bond Community Health Center represented, and
You've got the health department.
And I'm not speaking for the health department, but I can tell you what they do.
So for the Bond Community Health Center, we will usually get our vaccine once it's here in the county from DOH. And at that point, I will decide whether or not I would do a mass, a robocall to the community, and then I'd set up my outside facilities for mass distribution of the vaccine. So at this point, it's only targeted for our patients that are high risk that we're given the vaccine. But if the vaccine's available, then we have the means to distribute and vaccinate.
I would say the same thing at CarePoint. Once we are sure of the supply, then we will be more open to having people outside the CarePoint come in and get vaccinated. We'll probably have some community vaccinations. In fact, we've talked with Bond and neighborhood about having joint vaccination
Right.
events.
Exactly. I think similar things going on over at the Leon County Health Department, vaccinating people that are known to us, whether they are patients with HIV who are known to be immunocompromised, whether they're patients on PrEP who have self-identified as having behaviors that would put them at risk for this disease. That's going to be our first target, along with the contacts of known cases. Let's see. There was a question here, and the phone turned off.
You have to have my face.
If only, right? The question, a couple of questions from a local provider who says, I know that they screen, he says he's been asked this by patients, I know that they screen for all sorts of things like COVID, HIV, or other STDs. Why not screen for monkeypox? You guys want to take that? You want me to? Basically, unless you're shedding virus, the screening is going to have no value. We do not have a blood test. The test for it is a swab to find a living virus. So if you are not viremic and shedding it through your oral mucosa, or preferably we're actually seeing lesions and we're swabbing those lesions, that's where we get the live virus from, and that's how we can test for it. So it's not something that we could really screen mass population for. And in many ways, it's a similar challenge with the vaccine, the messaging around this. If we put out there that vaccine is available, the first thing that'll happen is the most worried well people who have almost no risk at all will come and want the vaccine. And some of the folks who have some of the highest risk behaviors and really probably ought to get the vaccine may not stop by and ask for it. So we're always in that dilemma where we're trying to communicate at levels of risk who should be seeking out the vaccine, trying to reassure those who are really not having any of those risk behaviors, or not in those circles of contact, not in those risk groups at this moment.
And I think that gets back to the message about that this is not COVID. I think people are still remembering COVID and how easily that was transmitted. And so everyone was basically at risk for COVID. This, as we've discussed, there are risk behaviors. And if you're not in those groups, then your risk for getting monkeypox is extremely low.
Good. This provider also asked the question, if a patient has a sore that they cannot explain and are worried about monkeypox, should they go to the ER? Should they go to the health department? As a person on the other end of that health department, I'm gonna say, go to your regular provider. Now, if you don't have one, then whether it's the health department, whether it's the federally qualified health center, probably not the emergency room, but maybe an urgent care center. Again, any place that can do a herpes swab or could diagnose you if you had a sore on your bottom parts, that's where you should go. Because the reference labs, Quest and LabCorp, are running these tests now on a regular basis. They're doing it with the same swab kits that we use for herpes testing. Again, most doctors' offices have them and know how to do it. We are protecting ourselves a little bit. CDC guidelines are that, I wear safety glasses, not these, but the wraparound kind. I wear a full N95 mask. I wear gloves, and not to protect me, but to protect all of the following patients from getting anything off of my clothing, I'll go ahead and wear a paper gown if I'm doing that swab. Dr. Applebaum, I'm going to give you this one, let you read it, and let you decide how to interpret and answer it. And meanwhile, Dr. Tinson had a question.
I have a question here from looks like the online. What type of screening questions for monkeypox are you asking at the health center? We're using the CDC's guideline. The first question is, have you had a fever? Do you have a rash? Have you had any contact with anyone with these symptoms within the last 14 days? And if do you have any swollen lymph nodes? Are you achy? Is there any malaise, which is tiredness? So we're just using those questions, and I actually ask them at the front desk. I have a little checklist, and if they have those, my MA will isolate the person and come and get one of the providers so that we can do a further evaluation. Usually isolate them into a single person exam room, and then we evaluate whether or not we think that this is a case of monkeypox. Initially, we were isolating outdoors, but I've allowed the patient to come inside. That's just not acceptable. So they come inside, and then one of us will go in. Once I put on my PPE, I'll go in and do a full exam on the patient, ask some other specific targeted questions.
Very good. And if there's any clinicians listening, we don't use, this does not require a negative pressure room. There were questions about that when that first came up. And I'm going to go ahead and answer this one before we get to yours, John, because I think it's a fairly quick one. It says, can someone be autoimmune even though they've not contracted monkeypox? I think by autoimmune you mean, can somebody already have immunity even though they haven't had a case of monkeypox? So this allows me to mention that there are people in our country who were vaccinated and don't know they've been vaccinated, right? Almost all the military, certainly anybody who was deployed. My son, before he was about to be deployed, he got the stabby kind of vaccination, with the old-fashioned version of the smallpox vaccine. That confers immunity. A lot of people before 1972 were vaccinated. So all of us old folks or middle-aged folks, depending on how you think of yourself, if we got a little scar on our arm, we probably have been vaccinated. And it was interesting. It was a relatively small study, about 250 people, but in the Baltimore longitudinal study of aging, they actually looked at older people, drew blood from them to see what levels of antibodies they had to smallpox, and they still had significant antibody levels decades later. So that vaccine did apparently confer a significant level of immunity and significant antibody response for individuals in the older age groups that got that smallpox vaccine, or for those who are in the military. Dr. Applebaum, I gave you a tough question.
Yeah, you did. So I'm not sure I'm going to answer it the way the author would want me to, but this question talks about the early days of the HIV epidemic, where there was significant transmission of HIV in places like bathhouses, where men would go to have sex. And so the question is whether or not public health should look at venues like that now and close them down. I'm going to say I think we're talking about a different disease than HIV. As we've mentioned, yes, it's transmitted through intimate contact, but it's also self-limited. It's not, way back, I think when this author was talking about this, HIV was basically not treatable in people. It was a fatal disease. Not so anymore, by the way. But I think we're talking about two different diseases, so I'm not sure if I were in that position to make that decision that I would close down places like that. I think gyms are another area where theoretically the virus could be transmitted. There was an article that was published this week that looked at a small group of men who have sex with men and looked at their behavior since the monkeypox was out in the community, and there's been surprisingly a measurable behavior change in number of sexual partners. So the MSM population has done this before, and I think they are heeding the public. Many of them are heeding the public health advice, and I think we just need to do more of that. I'm not sure closing down venues is appropriate at this point, but not my decision.
I mean, I would just say as a general principle of public health, punitive actions that seem like they're stigmatizing one segment of the population or blaming one segment of the population or trying to isolate a segment of the population generally do more harm than good. On the other hand, working with a community, allowing them to speak their own truth, figuring out the best ways to communicate messaging around risk reduction, and having champions with whom you have built trust over a prolonged period of time is going to be dramatically more effective than either stigmatizing or blaming or isolating a group. It tends to push things underground. It tends to actually make the problem worse, and it makes the ability of public health to have effective interventions. It dramatically weakens our effectiveness in that space. So generally, trust one of my most common things to say when I'm dealing with my public health colleagues, when they say we got to go educate the community, my response is, it's relational, not informational. Dumping knowledge and information out there is not the primary way to address this. Forming trusted relationships and working together will get us to a much better place. Dr. Riscala?
Just want to follow up on the awareness, just the fact that this is not only transmitted men have sex
Yes.
with men. That's why, closing that specific might not be, the best approach. Is increasing awareness and all of that might be.
Yeah, this virus does not care, and it will infect anybody who gives it that opportunity. There are just certain behaviors that give it a better chance to transmit than other behaviors. With that, we have come near to the close of our session. I want to make sure that I thank our panelists for. Is there one more question? Do we have a card, or do you want to go ahead and? I got you. Good. We will do our best to get that question to you, or we could get a microphone back to you. We've typically not opened it up for microphone questions because I've learned that the definition of a question as one sentence with a question mark isn't always followed by in large group meetings. Yes, sir.
Can I say something really quick? David Bowles, University of North Carolina, said in a presentation last week that a series of a couple hundred monkeypox patients, anywhere between 7 and 14% of them had been previously vaccinated for smallpox.
Okay.
It's certainly not offensive.
So it's not 100%, absolutely. And none of the vaccines are. Even what we've described, 84% for the Jynneos vaccine would be consistent with that number. Yeah, good. All righty. The final question. We'll see. This is a great question. I'm so glad we waited for this one. Assuming a woman is pregnant and develops monkeypox and gives birth, is it possible to transmit the virus via natural birth? It's actually possible to transmit the virus in utero. In other words, while you're still pregnant, it can pass across the placenta and affect the fetus. There is also concern about transmission at birth. There's also concern about transmission during breastfeeding. So this is one reason why, as I mentioned, if you were to get a case while you're pregnant, we would use the tecovirimat, the antiviral drug, for pregnant women, as well as we would use it for children under age 8 years old, even if they didn't seem that sick, in order to prevent those bad outcomes. If a pregnant woman is a contact of an individual who has a case, then the vaccine would be appropriate, and the vaccine is considered safe in pregnancy as well. With that, we're going to bring this session to a close and honor your time. We want to thank everyone for the gift of your time and being here with us. And for all of those out there in virtual land, thank you also for attending. And we hope there's some learning stuff that happened here tonight. Thank you. There are some reception opportunities out in the atrium, and drinks and food. Dr. Fogarty, did you want to? All right, with that, thank you.